Welcome to the Deep Dive. I'm your host, and joining me to unpack today's topic is our resident health policy expert. Glad to have you here.
Thanks for having me. Always good to be here for a deep dive.
So, I want to start you off, well, start the listener off, really, with a little thought experiment.
Okay, I'm right.
Imagine you're walking down a street in Belfast or Derry,
Right.
and it's raining because, well, it's Northern Ireland, so of course it's raining. And you stop a local to ask them about their health care.
I can guess where this is going.
Right. Because 9 times out of 10, maybe even 10 times out of 10, they're going to talk to you about the NHS. They'll, complain about NHS waiting lists or praise the NHS nurses. The logo on the hospital even looks like the NHS logo.
It does, yeah.
It's free when you walk in the door. It quacks like a duck. It walks like a duck. And here is where we have to basically shatter the illusion right away. It's technically not the NHS.
No, it isn't. And it's honestly the most common misconception about the region, even for the people who actually live there.
Which is wild to me.
Yeah, it is. I mean, while it sits under the broad umbrella of the UK's National Health Service, the system in Northern Ireland is legally and structurally a completely different beast.
Right.
It's called Health and Social Care, or HSC for short.
HSC. Which, let's be honest, sounds a bit like a rebranding exercise some consultant came up with to justify a massive fee.
It really does.
But you're telling me this isn't just an acronym change, right? The social care part of that title is actually doing some heavy lifting.
Oh, absolutely. It is the defining feature. In fact, for public policy nerds, and I definitely count myself among them, the Northern Ireland model is often viewed as the Holy Grail.
The Holy Grail of healthcare. That's a big claim.
Well, think about how it works in England or the U.S. You have your medical care, right?
Yeah.
Doctors, hospitals, surgeries. That is one silo.
Okay.
Then, completely separately, you have social care. So that's nursing homes, home help for the elderly, social workers. In England, those are run by local councils.
Right. Different budgets, different bosses.
Exactly. Different IT systems, different everything.
Which is the classic bureaucratic nightmare. You hear those stories where you're stuck in a hospital bed, medically fit to leave, but you can't go home because the local council hasn't signed off on a wheelchair ramp for your front door.
Precisely. The left hand has no idea what the right hand is doing. That is the global standard of inefficiency.
Yeah.
But in Northern Ireland, way back in the 1970s, and then it was formalized later in 2009, they did what everyone else dreams of. They combined them.
Medical and social.
Yes. Medical care and social services are integrated under one roof, managed by the exact same organizations. On paper, this is the absolute dream.
Okay, so it's a unique healthcare experiment that should theoretically offer this seamless coordination between, say, your heart surgeon and the social worker arranging your home.
God, that's the idea, yeah.
So today, our mission for this deep dive is to explore this. Because let me get this straight. We have a system that was designed to be the Ferrari of healthcare.
Yeah.
Integrated, streamlined, efficient.
Correct.
But looking at the stack of research we have for today, reports from the Nuffield Trust, the outcome stats, the waiting lists, this Ferrari seems to be sitting on cinder blocks in the front yard, missing an engine and like 3 wheels.
That is exactly the tension we need to explore today. The performance statistics in Northern Ireland are currently significantly worse than the rest of the UK.
Wait, worse than England? Because England isn't exactly having a great time with healthcare right now.
Significantly worse. And that is what we're digging into. We need to figure out why this integrated system, which makes so much sense on paper, this perfect structure, hasn't been the magic bullet that experts hoped for.
Why the only fully integrated system is performing the poorest.
Exactly.
Okay, before we get to the why, I need to understand the what. You mentioned it's called HSC. How is this machine actually built? Is it just like one giant office block in Belfast running everything?
Not quite. The history actually started back in 1948, separately from the NHS but parallel to it. But the modern version really comes from the Reform Act of 2009. They did this massive slimming down exercise. They went from 19 different trusts.
19.
Yeah, which is a lot for a population of less than 2 million people.
That's a lot of management.
Exactly. So they took those 19 and brought them down to just 6.
Okay, 6 trusts. That seems a lot more manageable.
You have 5 geographic trusts. So that's Belfast, Northern, Southeastern, Southern, and Western. And then 1 ambulance trust that covers the whole region.
Got it.
But here is the key difference. Unlike in England, these trusts hold the purse strings and the staff contracts for absolutely everything.
Everything.
If you work in a mental health clinic, you work for the trust. If you are a surgeon, you work for the trust. If you were a social worker checking on at-risk children.
You work for that same trust.
Exactly.
Okay, so if I'm a patient in, let's say, the Southern Trust, the guy fixing my broken hip and the person helping me wash my dishes when I get home are ultimately answering to the same corporate boss.
That is the theory. And that brings us to what we call the integration paradox.
I like that term.
You would assume, logically, that this integration would make the system vastly more efficient. If you control the whole chain of care, you should be able to move people out of expensive hospitals and into cheaper community care instantly.
Right. No arguments between the council and the hospital about who pays for the bed. Just move the patient where they need to go.
And yet, Terry Bamford's analysis from 2015 showed the exact opposite happened. Despite this integration, Northern Ireland has actually failed to reduce its reliance on hospitals.
Really?
Yes. In fact, reliance on institutional care, so keeping people in hospital beds or nursing homes, is higher in Northern Ireland than elsewhere in the UK.
That feels completely counterintuitive. Why would an integrated system cling to the most expensive way of treating people?
Bamford highlights three main blockers, and they are fascinating. The first one is pure politics.
Of course it is.
To move resources into the community, you usually have to close or downgrade hospital buildings. You have to say, look, we don't need this acute wing in this rural town anymore.
Oh, I can see that going down well. In a small town, the hospital is basically like the church or the local football club. You try to close it, and you lose the next election.
It is politically toxic. So the buildings stay open, and the money stays tied up in keeping the lights on.
That makes sense.
But the second issue is even more interesting. It's a culture clash. We have to remember that health services are free at the point of use.
Right. That's the sacred cow of the whole UK system. You walk into A&E, you get treated, you walk out, you never see a bill.
Exactly. But social care is means-tested. It's a paid culture.
Ah, I see where this is going.
Imagine you have an elderly patient. Let's call her Mary. Mary is in a hospital bed. She is medically fine. She's totally ready to go home. Now, the hospital bed is costing the system maybe £500 a night, but it's completely free to Mary. To move her home, she needs a care package. That care package might only cost the system £20 a day.
But because it's social care.
Mary has to undergo a financial assessment. She has to prove she can't pay for it herself.
And I'm guessing that assessment isn't exactly speedy.
Not at all. It takes time. There might be a dispute over her savings or her pension. So you have this perverse situation where Mary sits in a hyper-expensive hospital bed for 3 weeks.
Blocking a sick patient from getting in.
Exactly, while the bureaucrats argue over who pays for the cheap home care.
That is maddening. The whole point of the integration was supposed to remove the walls, but the financial rules just built them right back up again.
Bamford noted that the greatest difficulties lay in these differing values. The free culture and the means-tested culture just didn't mesh.
It's like oil and water.
And then just to add insult to injury, the tech was a disaster.
Oh, government IT projects. Always a favorite.
For a long time, the IT systems for health and social care weren't even compatible. Plus, patient confidentiality rules often prevented the sharing of info that the system was theoretically designed to share.
Wait, so the doctor couldn't even email the social worker?
Essentially, yes. So you have the outward structure of integration, but the skeleton inside the tech and the culture was completely fractured.
It's like buying a top-of-the-line smartphone but not having a data plan. I mean, it looks great, but it doesn't actually connect to anything.
That is a very good way to put it.
Okay, so the machine is jammed.
Yeah.
And this brings us to the really heavy stuff in the sources. The performance crisis. I was looking at a report from the Nuffield Trust in 2017, and honestly, the numbers are hard to wrap your head around.
They are very stark.
My first thought was, well, maybe they just don't have enough money.
That's the first place everyone looks, but the Nuffield report completely debunks that.
Really?
Yeah, it showed that spending per head in Northern Ireland was roughly £2,200 a year, which is pretty much exactly on par with the rest of the UK.
So they aren't drastically underfunded compared to England.
No, but the output, the result of that money, much, much worse.
Let's talk about those waiting lists. Because, we hear about waiting lists all the time. People say, oh, the list is up. But we need to contextualize the scale here for the listener.
It is a different magnitude entirely. Let's go back to 2015 just to set the scene. The waiting list target in Northern Ireland, the actual goal they were trying to hit was 52 weeks.
A year. Their goal was to make you wait a whole year.
Yes. And just for context, England's target at that same time was 18 weeks.
Wow.
So the ambition in Northern Ireland was nearly 3 times worse than the ambition in England. And they weren't even hitting that 52-week target.
That's unbelievable.
The sources mention that around 16% of the entire population of Northern Ireland was on a waiting list.
Wait, 1 in 6 people? That's not a waiting list. That's the population.
It creates a state of permanent limbo for the entire society. And it's not just elective surgeries like getting a new knee, it's emergency care too.
Right, A&E.
The standard target for A&E is to see people within 4 hours. In Northern Ireland, over 20% and sometimes up to 30% of patients were waiting longer than that.
But there was a scarier stat in there.
The 12-hour wait?
Yep. 12 hours in a plastic chair. You arrive at breakfast and you're literally still there at bedtime.
In February 2022, 16.3% of attendees waited more than 12 hours. And we aren't talking about sitting in a comfortable lounge watching TV.
No, this is a crowded, stressful, noisy emergency department.
Exactly.
And this isn't just about being uncomfortable or bored. I mean, this kills people.
It does. We really have to talk about the human cost here because the stats can sort of hide the tragedy. In 2019, Heather Monteverde from Macmillan Cancer Support highlighted this devastating statistic.
I remember reading this.
1 in 5 cancer patients in Northern Ireland received their diagnosis in an emergency department.
Let's just pause on that for a second so the listener really grasps it. 1 in 5. That means they didn't get caught by a routine screening. They didn't get caught by a GP referral.
Right. It means the system failed them at every prior step.
They likely had symptoms. Maybe they were even on a waiting list to see a specialist, but they waited so long that the cancer grew until it became an acute, life-threatening emergency.
They collapsed, or the pain became unbearable. They went to A&E, and that is where they were told they had cancer.
And by that point, your options are incredibly limited.
Exactly. Patients diagnosed in A&E have the lowest survival rates. It's a systemic failure that is literally costing lives.
And it wasn't just cancer, was it? We saw a grim pattern with homelessness, too, in the sources.
Yes, the death rates. In a specific 18-month period reported back in 2019, 205 homeless people died in Northern Ireland.
And again, to give context, Northern Ireland is small.
Very small. It has about 2.8% of the UK's total population. But those deaths accounted for more than 25% of the total UK homeless deaths.
That is disproportionate on a massive scale.
It suggests a fundamental breakdown in the safety net. Remember, this is supposed to be the integrated system. Social care and health care are supposed to be working hand in glove.
Right. If a homeless person is at risk, the health side and the social side should be coordinating to save them.
But the data suggests that simply isn't happening.
You know, when you read these reports, it's really easy to get numb to the numbers. But there was one story in the BBC sources that really grounded this for me. It was about a woman moving from County Armagh to Wales.
Ah, the Swansea case, yeah.
And so she moves to Swansea. She has a condition she's been managing or trying to manage back home. She goes to her new GP in Bristol, or Swansea, I believe, and hands over her medical file.
And the reaction of the doctor was very telling.
Yeah.
The doctor was shocked, visibly shocked at the standard of care she had been receiving in the Southern Trust. And the really heartbreaking part was that the patient herself didn't realize how bad it was.
That's the scary thing, isn't it? Normalization. If everyone you know waits 3 years for an operation, you just assume that's how long operations take.
You don't realize that a short flight away, people are getting it done in 4 months.
Right. When you are inside the bubble, you just accept the dysfunction. It takes an outsider, or actually leaving the system, to realize, wait, this isn't normal.
It's a classic frog in boiling water scenario.
So, if the hospitals are overwhelmed and the waiting lists are a mile long, the logical fix, the textbook fix is primary care, right? The GPs. If we can catch things early with a GP, we save the hospitals. How are the GPs holding up in this storm?
They are drowning just as fast. They are facing a massive crisis of resources and recruitment. Back in 2017, it got so bad that the British Medical Association, the BMA, actually took a vote to start collecting undated resignations from GPs.
Explain that to me. What exactly is an undated resignation?
It's basically the nuclear option. Every GP signs a formal letter saying, I quit, but they leave the date at the top blank. They hand them all over to the union leaders. It's essentially saying to the government, we have a loaded gun. If you don't fund us, we write in today's date, and the entire primary care system collapses overnight.
That is dramatic. That's like writing a breakup letter to your partner, leaving it on the kitchen counter, and saying, I'm not leaving yet, but if you don't do the dishes, I'm signing this.
It really shows the level of desperation. Now, they didn't hand them in, thankfully, but the threat was very real.
But amidst all this, there was an attempt to fix things, right? I read about them pushing for something called MDTs.
Multidisciplinary teams. Yes.
Is this the Cookstown model?
Yes. Launched in 2018. It actually goes right back to that original integration dream we talked about.
Okay, how does it work?
The idea is that you shouldn't just go see a GP for everything. You should be able to see a physiotherapist or a mental health specialist or a social worker right there in the local practice.
Oh, that makes total sense.
Yeah.
If I have a bad back, I don't really need a doctor. I need a physio. Keep me out of the hospital entirely.
Exactly. The Cookstown Hub had scanning facilities, minor surgery, a pharmacy, all in one place. It's a brilliant model.
And I feel like there's always a but in this story.
Always. You cannot roll out a major reform like that across a whole country without strong political leadership. And this is where Northern Ireland's unique political situation completely wrecks the party.
The political vacuum.
Right. We have to explain this briefly for the international listener. Northern Ireland's government is based on mandatory power sharing. If the two main political parties don't agree to form a government together, there is no government.
The whole thing just collapses. It's not like the US or the UK where if the leader quits, a new one just steps in. The lights literally just go out.
Correct. And from February 2022 to January 2024, the DUP boycotted the executive over Brexit protocols.
And obviously we aren't taking a stance on the politics of that, but the practical reality is...
For 2 years, there was no health minister.
2 years, right on the heels of COVID.
Right when the system was on its absolute knees. And crucially, because there was no minister, there was no proper budget.
So you can't hire staff.
You can't sign off on multi-year building projects. You can't roll out these Cookstown models because there is nobody with the legal authority to sign the check.
Tom Black, the BMA chair, said the crisis boils down to workload and workforce.
Yeah.
But you can't fix the workforce if you don't have a minister.
Exactly. It's like trying to drive a bus from the back seat. You can yell directions all you want, but you can't turn the wheel. And while the politicians were arguing about Brexit, those waiting lists we talked about just grew and grew.
Okay, we have painted a fairly bleak picture here. We have a system that is fighting itself culturally, drowning in demand, and headless politically. Is there any glimmer of hope? Is there anything on the horizon that might actually turn this ship around?
There is one major technological glimmer, if you want to call it that. It's called the Encompass program.
Encompass. It's very corporate. What is it?
Remember how we said the IT systems didn't talk to each other?
The skeleton was broken, yeah.
Encompass is the fix. It's a massive rollout involving Cloud21 and Tegria, which is a U.S. company. The goal is a fully integrated electronic health and care record across absolutely everything.
Hold on. I have to be a little skeptical here.
Yeah.
We have seen government IT projects in the UK before. They usually involve spending billions of pounds and then completely abandoning it 5 years later because the software doesn't work.
That is a very fair question to ask.
Why is this one different?
The main difference here is that they are buying an off-the-shelf system called Epic, which is already used by top hospitals globally, rather than trying to build a custom one from scratch.
Okay, that's smart.
And the scope is unprecedented. It covers acute physical health, mental health, community care, and social services.
So if I see a social worker about my housing situation and then 3 days later I end up in A&E with a stress-induced heart condition, the A&E doctor can actually see the social worker's notes.
That is the goal. If it works, it creates the second fully integrated system of its kind in Western Europe. It attempts to finally solve that information silo problem Terry Bamford warned about.
So it brings the digital reality in line with the structural theory.
Yes.
It seems like such a basic requirement for the modern era, doesn't it? Doctors should be able to see your notes, but I guess in this context, it's a revolution?
It is. It's the digital infrastructure that should have been there from the very start.
Yeah.
Now, will it solve the political gridlock? No. Will it solve the funding parity issues? No.
But it removes one of the biggest friction points in the system.
Exactly.
So where does this leave us? We started by talking about a unique experiment, a place where health and social care are one and the same.
It is a fascinating case study in the gap between theory and reality. Northern Ireland has the structure that health policy experts around the world argue for. They have the integrated model.
Right.
But as we've seen, structure alone just isn't enough. It has been bogged down by the difficulty of culture, the legacy of old buildings, and political instability.
It's a warning, really, for any listener whose local government is proposing this. You can't just merge two departments, change the letterhead, and expect magic to happen.
Absolutely. The lesson here is that integration is hard. You can merge the organizations, but merging the cultures, the free versus the means tested, is the real battle.
If you don't fix that, you just create a larger, more complex bureaucracy that is even harder to steer.
Precisely.
That makes you wonder. We always hear that breaking down silos is the answer to everything in corporate and public life.
It's the buzzword of the century.
But if Northern Ireland, the only place in the UK that actually did it, has the worst waiting lists and the worst performance stats, maybe the silos aren't the biggest problem. Maybe we need to stop assuming that integration is the automatic magic cure for modern healthcare.
That's the uncomfortable question that nobody really wants to answer. But looking at the data we went through today, we really can't ignore it.
Definitely something for you to think about the next time you hear a politician promising a seamless new system. Thanks for joining us on this deep dive into the health and social care system of Northern Ireland. We'll see you next time.